speaking about kidney disease in the elderly population. And I think the objectives were listed on the handout as well as on the evaluation. We're also pleased to have Dr. Lee, geriatrician, that's here with us today to help with discussion. So we certainly look forward to hearing the presentation. And one other bit of information, this will be posted on Nephrology On Demand audio and video slides either later today or tomorrow. Welcome, Dr. Singh.
Thank you, Cindy. Thank you for the time. I'm very thankful to all the faculty here and everybody that I've worked with here. You can learn a lot of things from the books, but there are certain things that you cannot put into words. Some etiquette, some other things that appointments were 3 months booked. So you couldn't get an appointment for 3 months. So there were not a lot of referrals for evaluation of kidney disease, but now that we're there, we're seeing a lot of new referrals, a lot of older folks being referred by primary care. And there are some questions that pop up in my mind also, which I've tried to list in there. And some of them, that's why I put common clinical issues, which this is not a detailed presentation. It is just addressing the highlights of the common issues that we face, which all the geriatric patients that we see in the office. So I just this was a YouTube video. This was linked in the Kidney News. Kidney News is a magazine that is put out by ASN, and there was a link to this video, so I clicked on it and I want to share it with you. Kidney News had an issue on geriatric nephrology in February. This was part of that. So let's see. It's about 4 minutes or so.
Hello YouTubers. A friend sent me an email the other day which contained a poem which he thought I would enjoy and would be relevant, and I'm going to read it to you, but there's a bit of a background story, so I'll read you the foreword to the poem, which says, "When an old man died in the geriatric ward of a small hospital, it was believed that he had nothing left of any value. Later, when the nurses were going through his meagre possessions, they found this poem. Its quality and content so impressed the staff that copies were made and distributed to every nurse in the hospital. And the poem is called Crabby Old Man. What do you see, nurses? What do you see? What are you thinking when you're looking at me? A crabby old man, not very wise, uncertain of habit, with faraway eyes, who dribbles his food and makes no reply when you say in a loud voice, 'I do wish you'd try,' who seems not to notice the things that you do, and forever is losing a sock or a shoe, who, resisting or not, lets you do as you will with bathing and feeding, the long day to fill. Is that what you're thinking? Is that what you see? Then open your eyes, nurse, you're not looking at me. I'll tell you who I am, as I sit here so still, as I do your bidding, as I eat at your will. I'm a small child of 10, with a father and mother, brothers and sisters who love one another. A young boy of 16 with wings on his feet, dreaming that soon a lover he'll meet. A groom soon at 20, my heart gives a leap, remembering the vows that I promised to keep. At 25 now, I have young of my own, who need me to guide and to secure happy home. A man of 30, my young now grown fast, bound to each other with ties that should last. At 40 my young sons have grown and are gone, but my woman's beside me to see I don't mourn. At 50 once more babies play round my knee, again we know children, my loved one and me. Dark days are upon me. My wife is now dead. I look to the future, I shudder with dread. For my young are all rearing young of their own, and I think of the years and the love that I've known. I'm now an old man, and nature is cruel. 'Tis just to make old age look like a fool. The body it crumbles, grace and vigour depart. There's now a stone where I once had a heart. But inside this old carcass a young guy dwells, and now and again my battered heart swells. I remember the joys, I remember the pain, and I'm loving and living life over again. I think of the years, all too few, gone too fast, and they...
Let's do a slideshow. Let's start from the beginning. We're gonna be talking about a little bit about physiology of renal aging, the common clinical problems that we see in the elderly with advanced CKD, and a few highlights about palliative care in patients with advanced CKD. I put these in there because when I started researching this topic, I thought, how do you define elderly? What is the age cutoff? Because when you're talking to people, no age seems old. The arbitrary definition, no offense to anybody, is not here. I mean, in general, is people age 65, and I think they took it because of this is where you get Medicare, and U.S. Census just defined this as older population. And then the other definition was about CKD. We're seeing a lot of referrals in older people who you cannot decide whether their GFR is a little low. Is this chronic kidney disease or not? So that's what we'll talk about with a little bit. Geriatric population is growing. 65 and over, we have about 35 million people now. The age group 75 to 84, there is 23% increase, and people greater than 85 years of age, there is about 38% increase in there. As you can see here, about 4.2 million people, 2000 census. And average life expectancy is also pretty good. If you can see, for females about 80, and for males about 75 years. So we're going to see a lot of older folks in our practice. These are the predictions. So by 2030, the estimated elderly population is going to increase to about 71 million. And baby boomers, baby boomers are the people who were born between 1946 and 1964. So when they start getting to the age 80, their numbers will also increase a whole lot. And they're estimated to be about almost 20 million. And by 2050, 1 in 5 adults will be older than age 65. The way the predictions are right now. There is an overall increase in the chronic kidney disease. As you can see, there is some increase in the younger age groups, but over the age of 70, as you can see from these light gray bars are 1988 to 94, and then 99 to 2004. There is an increase. Now, some people wonder, is it because we've changed our definitions, or what's the cause? But from the current definition of CKD, this is what we are seeing. The overall increase is from 10.3 to 13%, which is about 26 million, and this is all CKD combined. But when you take stage 3 and stage 4, we had 27% in the age greater than 70, and now we have 37.8%. Huge increase there. And for the younger age group, comparatively, it's not that much. We think that the increase is because people are living longer and these comorbidities are catching up. Hypertension, diabetes, and obesity. That's now older folks too. People who are growing older, they're growing with these comorbidities. This is data from our practice. When I did a search for people greater than age 65, we have about, in the last 2 years, we have about almost 1,600 new charts and 892 results for over the age 65. And that's greater than almost 55% and 56%. And this is all comers. This is not sorted out what we saw in the hospital versus in the office or somewhere else. But so any new fellows who graduate, they can pretty much expect to see these kind of numbers. Closer to 60% of your practice is going to be people over the age of 65. We'll talk a little bit about physiology of renal aging, and I put this because, again, in my I'm trying to think in my mind, can I get a referral for GFR 45 or 55? Is that a problem, or what should we do about it? So what happens? So in older folks, we lose some renal mass. We have arteriosclerosis of intrarenal arteries, just like everywhere else. Those arteries are aging also and deposit cholesterol. We have a decrease in the cortical glomerular number from ischemic changes. Some of the glomeruli are just dying because of the ischemic changes. And we also have decrease in the size and number of renal tubules. We also have some tubular interstitial fibrosis. So these are the changes that you see and gross changes that you see. Summary, the glomerulus, and this is one of the questions in the NAFSAP. What's the difference between changes in aging older kidney versus diabetic kidney? So both can have thickening of basement membrane, they have increased mesangial matrix, they can have focal global sclerosis. But over there in the question, they have mentioned hyperfiltration. So that's related to diabetes and not to aging kidney. Podocytes get diseased, interstitium, we have some atrophy, and vessels, we have atrophy and simplification. What that means is the efferent and the efferent and the efferent arterioles just join and bypass the glomerulus. So you do have blood flow, but it's not feeding the glomerulus anymore, it's just bypassing that, and that's called simplification. Functional changes, we have some decrease in the plasma, renal plasma flow. We have decreased GFR also. We have problems with sodium conservation. If you take a group of people and compare younger versus older, and if you compare, you put them on salt-restricted diet, and you see how the urine sodium does. In older folks, it takes a lot longer to get their urine sodium low as compared to younger folks. And same thing with sodium excretion. When you salt low somebody, older folks and younger folks, younger people are able to excrete their sodium quicker as compared to older folks. Similarly with urinary concentration, we have older folks, as we grow older, we have problems with concentrating the urine and the urine also. And that could be part of the problem why older folks have to go to the bathroom. So now, what's the normal rate of decline? What can we expect as people are aging? So this group did a population-based cross-sectional study in Netherlands. They studied Caucasian men without comorbidities, so they could not identify any problem. And they figured that 18 to 24-year-olds have GFR about 100 cc's per minute, and as they grow older, they found that the GFR was lower. What to sort out is there's something we just cannot detect, is this comorbidity effect or just age effect? On the next slide, we try to do a biopsy correlation. In their clinic, they did a retrospective study on living donors of all ages. They tried to study age-related structural changes in the biopsy. Okay. And they were looking for nephrosclerosis, which was defined as global glomerulosclerosis, so to tubular atrophy, interstitial fibrosis, and arteriosclerosis. What they found was that in the younger folks, you have 2.7% nephrosclerosis, but in older folks, you have a lot more, 73%. But the confusing part was the isothalamic clearance was not that much different in people who were living donors different ages. So that confused people more. Now, although you have a lot of glomerulus nephrosclerosis, but your clearance is still pretty good. So what's the difference then? In my mind, you can have nephrosclerosis, but what it leaves is that you have less reserve. So a lot of glomeruli are older. So if there is any injury or any insult to the kidney, then you're more prone to get acute kidney injury and more suffer from kidney damage, as opposed to younger folks who have a lot more reserve. So this is how I look at it. So their conclusion was the kidney function and chronic kidney disease risk factors fail to explain the strong correlation between age and nephrosclerosis. So interpretation of EGFR. So now we get a referral patient of 85 years old or 90 years old, and they come with a GFR that's listed. So what do we do with that? How do we interpret it? MDRD study had patients from 18 to 70 years of age, and the carrying was 1.2 to 7 in females, 1.4 to 7 in males. In CKD EPI, they did a sub-analysis, and the participant age was 24 to 59, and only 3% were older than 70. Okay. So still we do not have that 85-year-old person in there in the study, in these results that we act upon. CKD equation is a little more accurate than MDRD study across most subgroups. So if you have a choice of which results to look at, you can, and this is more believable than MDRD. Low GFR does have higher mortality. This Kaiser Permanente retrospective study, they studied the risk of deaths, cardiovascular events, and hospitalizations, and they found that these endpoints were more related with GFR 30 to 44 as compared to 45 to 59. So some people have started looking at stage 3A and stage 3B. They're not that commonly used in clinical practice, but something worth thinking about, since this group had higher mortality. So then, what do you do? So then, when you do get referral for these patients, who do you call back for follow-up and at what interval? So we think that for age 70, GFR 45 to 59 may be typical. Again, people to follow would be people who have evidence of ongoing kidney injury, which means they have either hematuria or proteinuria or declining GFR faster than this rate, and people who have complications, anemia and hypertension or high phosphorus. So if these complications are there, then we can call them sooner, as opposed to we do not have these complications. Maybe we can schedule their follow-ups a little further out. Okay. So that was about some aging physiological changes. Now another question comes is, what do you do? What are the goals for treatment of high blood pressure in the elderly? This is a common thing we face. You don't want to hurt anybody by lowering their blood pressure too much. So what should be our goal? Most people have isolated systolic hypertension. It affects 2/3 of individuals over the age 60. And we know that systolic blood pressure is a strong predictor of cardiovascular disease and ESRDs. GNC recommends across the board you bring people down to 140 over 90. But the SHEP group, the systolic hypertension and the elderly group, they do caution you that do not reduce the diastolic below 60 or 65, because that was associated with higher cardiovascular events. So in my mind, I can leave the systolic alone if their diastolic will start to go below 60, 60 or 65. And if people were complaining of angina, then we're looking at maybe diastolic of 8. This is the other study, the HIVAC study. It was done with indapamide and parenteral. People were over 80 years of age, and the goal was to reduce blood pressure to 150 over 80. And they did show a reduction in stroke, reduction in death, and reduction in heart failure. So, often we see patients greater than older than 80 years of age, and we are hesitant should we put them on medicine or not. According to this study, it is okay. It is okay to, and it benefits them for treating. But the goal is different. The goal is not 130 over 80. The goal is 150 over 80. So other things we can suggest to them: weight reduction, salt restriction also. Older folks have less salt sensitivity and less taste, so they tend to put more salt on their food without realizing. So that's something to suggest. And also, a lot of people have arthritis, and we're using NSAIDs, ibuprofen, ciprofloxacin, and avoiding or minimizing NSAIDs will help also with the control of blood pressure. As far as which medicines to use, all the classes of medicines are effective. Whichever you have more experience with, you can use. If they have particular cardiovascular mortality risks, then of course we go with ACE inhibitors and ARBs. Single agents, if you want to use, you can use either calcium channel blockers or thyroids. ACE and ARBs for cardiovascular risk. We can use true drug combinations and monitor for side effects, especially electrolyte disorders. Since we're using thyroid, we have more incidence of hyponatremia in the elderly. So maybe it's a good idea to bring them back after 1 week to look at the sodium. And also check orthostatic blood pressures in the office. I've given instructions after reading this to my staff that anybody's over the age 65, you always check orthostatic on them also. You check a sitting blood pressure and you check a standing blood pressure. Normally you would wait 1 to 3 minutes, but I think most people would take that much time if they are older. So next, what do we do with diabetes in the elderly? Again, prevalence of diabetes has increased by all databases, enhanced Medicare KEEP database. This is an estimate by 2030 we will have almost close to 50 million diabetics. And this is year 2000, we are right now about 28 million. So huge, almost double. And this is in developed countries. They have different data for developing countries and all over the world. But for developed countries, this is what we're looking at. There was an analysis done on the Renal results for when they sorted out for age over the for patients over the age of 65. 421 out of the 1513 original participants, and they studied the effect of losartan, and they did see that losartan, ARBs, goes-out of the diet. It removes doubling to 30%, and also was to reduce on the SRD 50%. These are standards of care proposed for elderly diabetics with CKD stage 3 and 4. For A1C, we aim for hemoglobin A1C less than 8.5. We don't shoot to the target of 7 or 6.5 because then they have more hypoglycemia. So blood pressure 140 or 90. We're talking about elderly diabetics. Hemoglobin 11 to 12. These are proposed standards, they're not enforced or guidelines, but they're proposed. This is what we should do.
Is this for they're using the age 65?
Yes. Cool. Now we come to advanced CKD and dialysis. So this is where primary care doctors can help us. Your folks, we should have a comprehensive geriatric assessment. We should be able to identify geriatric syndrome early in our screening of data. Predialysis education should include non-dialysis care also. I will talk all about this next time. So geriatric syndromes, these are the things that have really high mortality, falls, dementia, cognitive impairment, functional dependency, and frailty. Okay, these are the things that increase their mortality. A single fall in dialysis patient is known to increase their mortality, and if a dialysis patient has hip fracture, their mortality is 2 or 3 times more than other dialysis folks who do not have a hip fracture. Hip fracture is really bad, especially in diabetic patients. A dialysis patient. So treatment strategies, what we can do, again, orthostatic hypertension to avoid, polypharmacy. A lot of patients, especially nursing home patients, when they come with their list, it's just mind-boggling to just enter it in your computer. Some of them have almost 20, 25 medications. And some of them are duplicates also. A gentle exercise program. If there is a geriatric clinic in the area, they would benefit from getting assessed there. And the home falls prevention program. That is something where the nurses can go and check their home environment and suggest changes so that changes can be made early. Syndrome of frailty, that's when you have 3 out of these 5 criteria, when people are losing weight involuntarily, when they are fatigued all the time, when they feel weak all the time, when their walking speed has slowed, and when their activity levels have slowed also, they're not as active as they used to be. So this is when you can call somebody who's frail. And the thing is, these are very simple. There's no lab test involved or anything, but you can see they have the highest risk of poor outcomes, and they have the slowest recovery rate after any kind of procedure or anything. And then they have the risk of most iatrogenic complications, and they have the highest mortality rate. So now we talk a little bit about dialysis in the elderly. So this is from U.S. renal data systems. We are this is the point prevalence of ESRD patients, as you can see. About 2009 here, we have over 500,000 dialysis patients now. This is 2008 data over various age group distribution. As you can see, people over the age of 65, they constitute a significant number here, as you can see. Among them, this age 70, 79 is the highest growing number. They have the highest prevalence. And this is the incidence data, as you can see, age 65 to 69, starting from this green bar over here. They constitute a fair number too. And amongst them, this is the highest incidence group, 70 to 79 again. Cost of ESRD to Medicare, as you can see, this line is going exponentially high. We're almost up to $450 billion. And ESRD costs are increasing, but the total increase is a lot more than what ESRD is made to believe. We hear a lot about dialysis, but costs have increased, but total Medicare has such a lot. And these bars, they are percentage of Medicare programs, and you see about close to a little less than 6%. This is total Medicare dollars spent by type of service. All of them have increased. We have more inpatients, we have more outpatients, we have physicians also are getting more because they're seeing more number of patients. Hospice is very little, as you can see. And this is really important slide because a lot of patients and their families, when you're trying to decide should you start somebody on dialysis or not, and they ask you what's the prognosis. Well, this is what we know from pooled data that for 85-year-old plus, when you start them on dialysis, the mortality is 48%, and this is 1 year survival is 48%. That means only 1 in 2 people will live survive beyond 1 year. This is adjusted all-cause mortality, ESRD, and general populations, and you can see general population mortality is right here, and dialysis way up there. It is 65 plus. And across the board, dialysis has more mortality, but as you can see, 65 plus has a big difference for the same age group.
Does it matter as much what caused the ESRD in an older person versus a younger person? I think we all know that diabetics do terrible because of their other comorbidities.
Diabetics do worse across the board. But in older folks, I don't know. I don't think so.
Can you go back one slide?
Yeah. So what are the options available for older individuals? We can do home-based therapies, which are peritoneal dialysis. We can do in-center dialysis. And some people can even go to transplant, depending on how their functional status is. Home therapies are underutilized in US. PD is more common than home hemo. In comparison with different countries, we have home therapies in Canada about 18%, UK about 16%, and for US it's about 6%. Peritonitis rates, they have gotten better because of better connection and better connectology and the antibacterial ointment. So we can be less anxious about putting people on dialysis, on PD. Barriers to PD, they have decreased strength, they have decreased mobility. The bags are shipped and they're left outside their doors, the peritoneal dialysis bags. So then it's up to them how to get them inside the house and store them. So that involves some work. Again, a decrease in older folks, we have decreased manual dexterity, and some of them could have poor vision; they just cannot see properly. It does help if some of their family members can step up and help them. We have put people on peritoneal dialysis older folks, and their family members actually help them. Really frail individuals really help them. Ended up doing some of that. Without their family members' help, they will know about that. So, hemodialysis, more than 13,000 patients is over the age of 80. Problems that we see with people and other folks who want hemodialysis, find that the fistula the veins are so weak and calcified that it is just hard to get a functional fistula. Sometimes it takes 2 or 3 tries, and that involves several trips to vascular surgery office, back and forth, in addition to the hemodialysis trips to the dialysis center. So it is a big trip. We have increased hospitalization, the algorithms tend to be lower, and there is a increased risk for depression and diabetes. So this is the topic I find you have to learn it one way or the other. It is difficult to talk to patients about this, but when you just have to say it's part of my job to do it. This past weekend we had a lady who was 89 years old in hemodialysis, got admitted to the hospital for a hip fracture. And when I go to see her, she says, I'm tired of everything. I feel I'm losing weight. My appetite is poor. I just feel tired and weak all the time. I don't have any desires, nothing to do. So then I bring up, are you talking about stopping dialysis? And she looks at me, I mean, I would lie. I just wanted to ask you, do you still want to continue or not? So why did you bring it up? And so I answered the guy there, and I said, well, this is part of my job to ask you time and again. See if you want to continue with dialysis, if you have something you're experiencing, not for you. But that is one experience. On the other hand, people ask you, what is, or people actually don't ask you, they should be, they want to know, but they will never ask. Then some of the retrospective analysis we talk about, they say that physicians should be the one who should bring this up. About the mortality, about DNR, about palliative care, about withdrawing from dialysis. But in actual reality, it is very hard to do.
How do you document it where it's honored by other physicians? I have had 2 examples in the last 2 weeks of patients that I took care of, 85 plus, don't want dialysis, saw them in clinic, documented it over and over and over again. They end up in the hospital with something else, and I'm consulted to come do dialysis. They raise the issue with families who say, we want everything done.
Yeah.
But you're not honoring the pact that I made with this patient and documented over and over and over again.
And that is really important, because I think, but this is my personal opinion, I think when we are having these kind of conversations, we have to have a responsible family member in there with them, so that there are other people who can give their input, and when I have these conversations, I tell patients, you're not the one who are sitting there with a family member. You're not the one who sit there for 4 hours tied to the machine. It's your loved one who's there. So we have to respect their wishes, and it really helps if they are present during those conversations. And one time, this is what I did. I told this patient who was GFR of 12. I told him, come with your family member next time. Come back in a couple of weeks. We'll sit down. We'll talk again. Okay? And very frail lady. She walks with a walker. She's 89. GFR is getting to 12 now. And I asked her, I bring this up again. This was the whole purpose of that visit. We just have to spend more time. And then her son, asked me the same question. So what is the prognosis? Are you going to be able to prolong her life? Or by how much? There is a competing issue. There is a competing issue of cardiovascular death with death related to dialysis. So I have this conversation. I don't know if they understood the whole thing or not. It's really hard to explain to the patient also, or family. So then I said, okay, go to the dialysis center, go look at it yourself. Okay, so once you leave the office, give them the phone number, you go swing by the dialysis place, and see if she'll be able to get out of the car and even walk to the dialysis place. And that opened their eyes.
That's a good trick.
It takes multiple steps to do that.
Just for documentation purposes, obviously we want to document what we know, but has anybody used the most form? Anybody know the most form?
I think when Susan Ray was here, she mentioned it, but I think that was maybe just a very brief introduction.
So it's a physician order. It's an actual order, just like the DNR form with the yellow form with the stop sign on it. Somebody has to sign it. Most form you can fill it in there saying the patient does not want dialysis. Sign it. It goes with the patient. If the EMS people are in the patient's home to pick them up for some reason, most form goes with them to the hospital. So we have a portable form that travels with the patient to ensure that there's documentation. Otherwise, you can tattoo it on their chest. But, there's sort of the idea is that the order goes with the patient.
The other part could be that note for that day goes to the identified primary care physician. if we ask the patient, who is your primary care, who else wants to know about this? So that note gets passed to primary care. But this is our conversation, and this is what we have. So you should be on board. But I know with the hospitalist and everything that's different. The hospitalist is a different position, and primary care is a different position. But I think having family member in that room and having that conversation, that's the key. Principles of palliative care. We have an agree upon and to optimize the quality of life and relieve suffering. We do simultaneously do other appropriate medical things. We do not stop the treatment. We just not going to do aggressive treatments. It's not end of life or hospital care. And we still treat them for other things. This is appropriate for all patients. And if you have a palliative care service too, and also your wedding is really big, but getting them involved in all difficult cases that helps. We have very efficient, very nice, responsible palliative care service over there. We have 2 physicians actually, and they go over all these things. Components of palliative care, we have advanced care planning, which is again updating the prognosis. We talk about goals of care. We talk about preferences, and we hear the patient narrative, what they want to do, what are their goals, if they are able to tell us. We focus on pain and symptom management. We involve the family, create a sense of control over the patient health, to relieve potential burdens, because it is a big burden on the family member too, because they're trying to decide, will I kill my family member if I tell them not to go on dialysis? And then hospice referral ultimately. So this was a preferences, end of life preferences survey. It was about 584 different kind of renal patients, predialysis, some PDs, some transplants, and hemo patients. What they found was most of the people were felt well informed about their medical condition, but then they also reported that nobody has talked to them about end of life issue in the past year. And a lot of them were optimistic too. They thought that nothing's going to happen to them. Only 18% thought that their health would worsen during the next year. And I'm not surprised that the 69% don't know what the palliative care is. I mean, this is a lot of patients don't know a lot of other things also. But this was the surprising part to me, that patients do want to hear about it. They just don't say anything about it. They just want you to bring it up. And again, the other things were that some patients regretted that their decision to start dialysis, and they felt that it was made by others. Their doctors decided or their family decided, and they never wanted to go on. But then again, it just needs more time involved, time on the physician's part, time on the family part. Everybody just sit down and have to talk about it. So we know that more than 80 years old, we have dismal survival in dialysis patients. Average 1-year mortality about 46%, and their median survival is 1/6 of age-matched non-dialysis population. That's how much high mortality is dialysis. Prediction of mortality, and this is an important slide also. This is what, if you look in your, this is what we do, but without realizing. Okay? We look at their age, whether somebody is somebody is old, but their mortality, we know that their mortality increases with age. Then we look at their comorbidities, especially ischemic heart disease, and this is what I found is really true. If they have ischemic heart disease, they do not do well, no matter what you do, no matter how hard you try. Diabetes, functional dependence also makes a difference. Poor intellectual capacity, then we have to get their family involved. They have low albumin, meaning possibly meaning poor nutrition. They have peripheral vascular disease, sometimes even late referral if you have to do things in emergency, even that makes a difference. And then nursing home ESRD syndrome. There was a recent study in clinical CJSN that starting patients on dialysis who are nursing home patients is not a good idea. They have really high mortality within the first year, and dialysis or no dialysis really do not make a big difference. This is an online calculator which let me just show you what this means here. So as you can see, this is programmed calculator. You can put serum albumin in there, and then there is something called a surprise question, where would you be surprised if your patient died in the next 6 months? Yes or no answer. And then their age, whether or not they have dementia, whether they have peripheral vascular disease, and then it gives us a predicted survival.
Can you run that, man?
Yeah, sure, let's do that.
Put 80 in there. For
80, okay. Okay.
And what's your surprise answer? Not surprised?
That's fine. We'll leave the other thing.
Sorry?
That's good.
Uh,
Just remember, I mean, that's basically the same answer that your US30S data set said. And correct me if I'm wrong, Cindy, but you can't get in that data set unless you survive the first 90 days of
I
dialysis.
think that's correct, because I don't think they collect.
Right.
The
They don't collect
that's
data
right,
on
they
those.
collect
So
data.
the mortality,
Not too
when you're
many.
thinking about starting on somebody, is actually higher than that.
Correct, because you have to make it to that time before you're even captured.
So
And
I've had
another
to-
point, quickly, that it made me think of this, when we reviewed mortality data for the Eastern North Carolina, Virginia region, a lot of the patients in dialysis units that passed away were older, age 65 or greater, and they actually passed away when you looked at all comers many within the first 3 months of dialysis. That was very interesting, and I did not really think about that here until you asked that question. But it was just reviewed recently, so those are a couple of very good points.
So it is a big deal. That's why people are making all these efforts to predict ahead of time, see if there is any other way we can put it into numbers. You know, because people ask you this, and then you can either give them a estimated or approximate answer, or something like this. You know, if this is 80% mortality versus 20% or 30% mortality. These are just additional tools to help. So other tools, we got a comprehensive geriatric assessment, hopefully from primary care, from Geriatric service. This is another VES13 scale. It has a bunch of questions where you score them from 0 to 10, and if you have really low score, you're okay. But if you have high score, you have a higher, you're a frail person, and you have a higher risk of mortality. And other things we can observe. You don't even have to make them do it. You get up and go. And then when you ask them to get up and sit on the exam table, and then you can just figure it out then. From sitting position, without using the arms for support, when they walk 10 feet in 10 seconds, or not. If not, then you're a frail person.
I don't want to take that.
And then again,
That's my arthritis.
It's actually 20 feet.
20 feet.
There and back.
That's impressive.
Yeah, so go 10, yeah.
Mhm.
And then again, rapid chair ride from a seated position.
Is one fall?
Make sure.
So again, it's this simple thing, you know, can you rise from the chair without using the arms? That's also. So what we're trying to do is we are trying to figure out, is this patient a healthy patient in the healthy category, vulnerable category, or in the frail category? in healthy category, which would be the most optimal dialysis candidate, they are a local person, they still come to their yard and they do whatever they want, they drive, independent person, so that is the optimal dialysis. Vulnerable is our more typical dialysis patient. They have all the things actively available, some help needed there, some help needed with instrumental activities that they were doing. They can do one or the other, the rapid chair rise test or get up and go back. One of them they can do, one of them they will fail. Sort of in the middle. So that's most patients we see. And for them, we can maybe do a time limited dialysis. Okay, let's see how you do after 6 months. And if you still feel like you want to be on dialysis, we'll continue. And if you don't want to be on, then we can talk about it. All that's really hard to do to take away. So then they'll know.
Well,
but
and I was going to ask Cindy, of those people who died in the first 3 months, how many said, you know what, I don't want to do this?
And I can't.
Trial.
Yeah, because I do a lot of trials. I have been humbled so many times through the last 25 years of who I think is going to do well and who I think is going to do poorly, and I get surprised regularly. So I do a lot of trials, and my trial period is 6 weeks, because if they hate it and they can't get to the room and the 3 times a week's driving them crazy, we'll know pretty quick.
Yeah.
There were a subset of patients that did live with it, and they had been referred to hospice and things like that. So you did see
Yeah.
that list.
I thought USRDS reported if you were off dialysis at the time of death, it was not reported as death. Is that not correct?
I don't remember. I don't. And I mean, you might be able to speak to that. If you, I can't.
Right. No, I think that's sort of
I'm trying to remember
it's
the
sort of like the
difference
hospital
between-
trying to get you on, down the hall a little bit before you die.
I can tell you more of a dialysis company's definition than I know for sure USRDS, but I thought they were trying to match.
Okay, so it could have been Fresenius or DFS or somebody
Right, and I
else.
think Fresenius has recently changed.
I
If
see.
you stop, then it's there, and I thought it was, yeah.
what I've had to do is, Fresenius makes you sign in the chart the reason to take off of dialysis. Either they recovered kidney function or they died from whatever cause. So it is in their progress note. So they must be reporting it to somebody. Otherwise, they don't need to collect that data. And then the frail individuals, those are the suboptimal candidates, and we'll talk about the phraseology here too, and what words to use. We're using now suboptimal instead of poor candidate. So they consider non-dialysis management in these patients. This is another tool to the kind of the performance status. Good functional status with higher scores, 80 to 100, and then as the scores get lower, then you are more frail or more vulnerable. This is the RPA tool. They have the medical indication for intervention. These are the questions to think about. Then the patient preference. Give the patient big picture, engage the family, and see what they want to do. Talk about quality of life, and then contextual features. Are there any conflicts between family members? Our description of the patient wishes consistent? Do the patients understand what they're trying to say? And a lot of times that is also difficult because patients do not know what. We know we've done dialysis for a while, so we know what to expect. But patients may have never been to dialysis center or have not seen or known any dialysis patients. So it's really hard for them to judge ahead of time. And for them, again, we go to a trial of dialysis, and just have maybe 6 weeks or how many hours, we can decide, and then we'll sit down and talk again. To non-dialysis management, we do advanced care planning, we implement patient goals, we still manage their anemia if they need EPO, and if they're reporting tiredness, we can do iron and info to bring their hemoglobin between 10 and 12. We can still manage the bone disease, phosphorus, PTH, we can see if they wanted to desensify or not, or activate vitamin D. Fluid balance with Lasix, and acidosis with Bicitra, bicarb supplementation, treat their blood pressure also. And for these, we can think about it in these kind of patients who are older than 75, high level of comorbidity, again, impaired functional status, low albumin. And then the surprise question, and you would say, no, I wouldn't be surprised if this patient passed in the next 6 months. But again, these are just guides. There is really no way to predict. We can be wrong in a lot of instances here. Again, in this study from clinic CJSN, the question was, is maximum conservative therapy or non-dialysis management an equivalent treatment to dialysis for elderly patients with significant comorbid disease? Okay. People who are frail, should they go on dialysis, does it make any difference? And they found that the hospital-free days, and this is what I quote to a lot of people also, their hospital-free days were almost similar, although they lived longer. They might live to 2 years, but they spend a lot of time either at the dialysis center or at the access center or in the hospital, and this is a graphical representation of that. So this is the maximum conservative management on the top, and all hemodialysis patients, and you can see that these are the hospital-free days. The rest of them were outpatient dialysis or hospital inpatient. And I've quoted this to a lot of people, and they seem to understand this concept better. Some people will say, it doesn't matter, I'll take my chances. Maybe I won't get sick. Again, this was an interesting study also published in AJKD, delaying dialysis. So what they found was that if you do very low protein diet, 0.3 grams per kilogram, it can safely delay starting of dialysis. No, not to the point of poor nutritional status, just low protein. And
having thrown out the positive, you know that it's not nutrition, but it's not. When you talk about quality of life, is this
and that's why it's important to sit with the patients. And these are suggestions. We're not enforcing this on anybody. If somebody can do it, this is the result. They'll delay their going on dialysis. If they want to eat and be on dialysis, that'll be fine. It's okay. I mean, it's prouder. I'm just kidding. No, seriously. But again, these are suggestions. Some people will be able to take it, some people won't be able to do it. And Bowen is right. Low protein diet is no fun. Just try to stick with salads without any chicken or stuff on. It's hard. So RPA has this shared decision-making guide, and I brought a summary of this executive summary. I don't have any copies, but you can review it as usual. We'll get the high points. These are the points in there that we established a shared decision-making relationship, not just manage their anemia and phosphorus. We also talk about palliative care in that. Once we have a patient, maybe they're coming second or third time, we can talk about it. Informing patients about diagnosis, prognosis, treatment options, estimate prognosis, same thing. Advanced care planning, talking to them about foregoing dialysis, or time-limited trial of dialysis. If there is a conflict, we have some process of conflict resolution. We can refer to palliative care. So this we've talked about it. So this is the phraseology that some people have started to suggest, words to use and words not to use. So use the word to forego instead of to say let's hold dialysis or let's withdraw them from dialysis. We mentioned that patient has a right to forego dialysis. We say non-dialysis medical therapy instead of saying conservative therapy, and we say patient is suboptimal or non-ideal candidate instead of poor candidate. They think that this refocuses or reorients people's hopes and minimizes their discomfort. This is a slide about the Medicare hospice benefit. You do not have to withdraw from dialysis to get hospice. You can have another terminal condition. For example, you can have a very severe heart failure where EF is 15%, or you can have some kind of cancer or some other terminal diagnosis where expected lifespan is less than 6 months. For that, we can get hospice benefit, and patients can continue dialysis. But you cannot get hospice just for plain ESRD and continue dialysis on top of that also. For other diagnoses, you can continue dialysis. So, just concluding, EGFR does decline with age, but may or may not mean clinically significant chronic kidney disease. You may or may not have to do anything about it. Peak incidence, this is the age group to watch for, 70 to 79. They have the highest incidence. ESRD, we all know that it has significant morbidity and mortality. We talked a little bit about treating very elderly, older than 80 years old people, their goal of blood pressure less than 150. And it is okay to use ASMARBs to slow diabetic renal disease in the very elderly. And then again, renal replacement therapy discussions, we should talk about maximum conservative therapy and tell them that that is an option. We will do everything short of dialysis. Some people might choose that, some people might not. These are the references, and these are some other online resources. There is a very nice ASN slide presentations and recorded lectures. It's on the ASN website here, and then this is another kidney end of life, and I'll go to this link in just a second. We also have ASN online geriatric nephrology peritoneal, if anybody wants to look at that also. When I started researching this topic, I thought maybe a couple chapters and I'll be done. But there is so much more information out there in the last 5 to 6 years, and rightly so, because we're going to be seeing so many more patients. Let me show you this thing here. I did not know about this before until I did the research for this. So the Kidney End of Life Coalition, they have a lot of educational resources on their advanced care planning, and just like Dr. Lee was mentioning, the different forms that are available, the MOST form, and there is a POLST form for advanced care directives, kind of on the similar lines. Some other resources.
Mentioned to emphasize that talking about advanced care directives and end-of-life issues and palliative care is like smoking cessation conversation. How many times does it take for a person to hear it before they start thinking about it, before they start acting upon it, and before they make a decision about it?
Absolutely.
And so that example with your patient who looked at your tummy when you said something about your fracture and underlying sort of pressure, that may be the first time the patient ever heard that before.
Yes, yeah.
But sometimes hearing it from 3 different physicians, 4 different physicians, multiple times, that really helps them process the information. And so I would say don't be discouraged if your patient sort of looks at your tummy and you say, you're really end stage, whatever disease state that you're in, you're at a very high risk for having bad complication and dying. Don't be afraid to say that, and they sort of think that you're sort of talking about some funny stuff. It takes multiple times for that conversation to take place.
And I think that's another point, to exchange notes amongst different practices. So if we send our notes to the primary care doctor, and then next time they see, they can highlight the same kind of issues and talk about that. Just like you're saying, 2 or 3 people you have to hear it from different people to make sense out of it. You may not believe one person, you're meeting the first person. But I think a lot of times you don't have the luxury of seeing them every so often. You can only schedule so many follow-ups. So here the other physician education resources. This was nice website, and they have symptom complex and different type of algorithms for pain treatment. Of course. Jean Hawley, Alvin Moss. If you see, most of these are written by these people mostly. And this is Dr. Richard Schwartz. He's the one who put that call factor. No, that's Steve. But most of the articles are written by this faculty. Dr. Oriopoulos, his name is not there. It's on an article, but he's a guy from Canada who knows a lot about this also.
Really good target talking patients. The key part of the equation is
one thing that might help with that, I think the parents are very well taken. This seems to be mentioned over and over again, and we probably mention even as we think about story analysis in our clinic population, and then now that we're doing CKD education, like with Linda, Joe, and Shiana, this will be another time for them to hear it again and make sure that that really is part of our CKD education in this program. And that's where I think communication is so important between the senior physician and who's going to be providing the education, so we can make sure that the patients are hearing the same things and we support them.
I think also these discussions are important to crises. Sometimes we know it's less. With that being stable and tolerant of the point of and you go ahead and one step further, suppose so. I sometimes can get the documented plan. I like the way it's in hospital recently. I imagine you know that plan is what you're doing. Sometimes I think it goes a little easier than kind of having to do the 3 or 4 and go crying and go trying to their chair and this is all you. Well, not all you, but a lot of information.
And this is another survey instrument. It's called the ES13, where patients can fill this by themselves, and that kind of gives them another insight on how their health is. And you score it by, in general, your age. What would you say your health is? And you get points for these things. You can say how much difficulty you have with stooping, lifting, reaching, riding, and then shopping, managing money, these kind of things. So if
we need to put these in our clinic drawers and those most forms.
so this is a copy of this thing. It's on the web. That's where I got it from. So while they're waiting, when the doctor is busy with somebody else, they can kind of fill this in, and then that'll give them a little insight about how things are with them. 0 to 2 score is good. Higher scores are worse. That means they're on the frail side.
For me, can you get I'm about slide 15, somewhere on there.
While he's going there, I'll just mention that, and Harmeet mentioned this too, that the American Society of Nephrology has their geriatric curriculum, and Dr. Singh actually wrote a chapter of that, bone disease and calcium abnormalities in elderly patients. So that's another resource, and Dr. Singh participated in that.
It was the point prevalence of ESKD.
Point prevalence, okay, it's next.
15, 12.
Point prevalence.
Oh, that's good enough.
Yeah.
What is going on there at 70, 79 years old? What is that?
I have a theory. The theory is that you have to work till you're 70 now, so you don't even go see a doctor till you're not working anymore. And then they say, congratulations, you have advanced kidney disease. What?
That's true.
Just a thought. I mean, I think people, how many times do we have to hear, I can't come, I have to work, I'll lose my job, I gotta come this time.
Maybe that's it, Jay, because I mean, it's an incredible bell curve, except that one spot.
And you're right, a lot of people that I meet over there, they have been working in the mills and they have been working in the, I mean, for people say nobody talks less than 25, 30 years. You know, I've been working 40 years. You know, so you're right, they probably don't have time to get into their health and get checked. Plus, we didn't know about CKD back in that time.
Has that existed through all versions of the USRDS over the years? Does anybody know?
I do not.
I just compared the 2008.
I've just never seen that before.
But you know, my father never saw a doctor till he was retired by 7 years, since he was in Korea. And then he went to the doctor and he found out he had high blood pressure and this and this and this, and then guess what? He didn't want to go back because that doctor was the reason he had all these things.
Yeah, I think a good catch is, you know, nobody likes to go to the doctor, but a good point is when you get insurance physicals, you know, when they come and draw your lab and they ask about all these questions. That's where you can catch if you have any elevated cholesterol, or I mean, it's a pretty comprehensive test that they do. If you have urine protein, or you know, something, that's the time to.
So about, I don't know, 7 years ago, Bob Schreier, another very elderly nephrologist, went on the warpath against the MDRD because of its ability to overestimate the prevalence of VSKD in patients with stage 4 and greater renal failure. Now, the drug companies have caught on to this. You may have seen the Biopsy people are all saying, well, we standardize this to cover off gall, which is true. Years ago they did. And there's about, they're saying about a 9% overestimation of the renal failure, which of course their issue, and that is you have 9% less drug than you should. But it's very true, it looks like. But the sad thing is now all of our guidelines are based upon this flawed data.
Yes.
So we interview, if we insert true data into the flawed paradigm, it's still wrong.
We still have to use clinical judgment.
I think that's job security. Somebody has to interpret that information and make sense out of it.
I was delighted to see you talk about the hypertension control goals in older folks. It's amazing how many folks I get here that can barely stand up because they're overtreated.
Yes.
And I back off and they feel great and they think I'm wonderful and they're running 150 over 80 and it's fine for them.
Then they go see their primary care doctor.
And then they get, yeah, well, and I'm not throwing bricks. I mean, we're being guidelined to death, but not everybody fits into guidelines, especially the older population.
And that's where the role of education comes in, sharing the information. Whoever knows can share with other people.
There's no prospective data that are controlled on the diastolic issue, but I believe in it very well. And of course, I think you cited some needs down. But they're going to go back as a secondary analysis and do a chord. And Karen, I think you know we're going to do Sprint the same way. And we may actually have prospective, even secondary outcome with the diastolic blood pressure.
I think that would be helpful.
Yeah.
But these are the common things that I've, you know, now I do all clinical, and this is all I do all the time. And these are the most common questions that I've encountered in the clinical practice.
For me, the mortality on dialysis, is that strictly in-center or is that dialysis PD and?
You mean 1 year?
Yeah.
Yeah.
All modalities.
All modalities.
So what is it?
So okay, so that's the other question. Which modality is better than, is hemo better than PD? The question is, how do you compare? Because you select for patients to begin with. So there, whatever suits the patient's lifestyle and preference, that's what we go with. So far, what we know from retrospective or whatever kind of data, they are both fine. They're both equivalent.
But I know that for someone who's 80 or even more than 70, we don't, maybe I'm wrong, but I don't assume that they can do PD.
That's where the role of family members come in. And I personally have heard, let me tell you a story. So 84-year-old lady who, not even, when she presented, when we were called, her creatinine was 3.5. It was the first time we were sick. She has some proteinuria, she has atrial fibrillation, her blood pressure fluctuates between 90 to 160, and she has massive edema, just lower extremity edema. She has pulmonary hypertension, but she can talk, she can recognize her family members, she's okay otherwise. We try to diurese her and we fail. We cannot get the lungs so much fluid off by dropping. So we talked about PD, and that's where I talked about bringing the family member. So I have these conversations with our daughter. I've spent about 3 or 4 times, a full hour of sitting there, just explaining the PD. She went over there to the PD clinic, talked to the PD nurses, and got a first-hand perspective on what she was going to be doing for her mother. We have very supportive vascular surgeons. They're there to put the PD catheter in her frail condition, got anesthesia on board. So then she had issues with leaking. She had so much subcutaneous edema that was difficult for the catheter to see it. But we got her through it. And 4 months into that, she walked into the PD clinic. She walked without her walker. I think that was her best moment, and after that she got some other cardiac stuff. But still, I mean, she got 6 months out of it, and I think it was worth for her and her daughter to be in. And she passed on to her. But she did okay. And same thing, this other guy, he had atrial fibrillation. He chose to do hemo because both him and his wife just couldn't be doing the bag. It's a little too heavy for them. So he's 79 or 81, same atrial fibrillation. Atrial fibrillation, I don't think is a good thing. But so he had the same thing. He had folic acid in there. He had the bilateral stents. He just multiple recurrent UTIs, bedridden, and very pleasant guy. When you talk to him, his goal was just to go work in his yard. That was his goal. That's what, if you can get me to do that. So we got him on hemo. He had the catheter for the longest time. He's the guy who had to be on Coumadin for atrial fibrillation. And when they did the access, he would just come and bruised on the whole arm was like swollen blue. We did get to use his access few weeks, I think, but then again his veins were so weak. So he lived for a good year, a little bit over a year, and it was good for him to be on dialysis. But we were very upfront with the prognosis. We always compare to what you started from. You started from a bedridden state, and now you can walk into the dialysis center. This is what I told him I look at. I know we're not prolonging your life by a whole lot, but we are working on quality of life. To be able to get you to do what you want to do.
I think MJ's point's very valid. You get a population, I think all would agree is elderly, specifically the greater than 80-year-old population. And I had a clinic patient that was going on to pretty well until about 2008, and for some reason she developed, we still don't know why, bilateral DVTs, and then began to have edema very similar to what you describe in your patient. That we said, well, I guess this is all post, DVT issues, and could never really get her volume status control, but never pulmonary edema, just her lower extremities. But her creatinine was humming along in the 2.5, 3.5 range, and slowly going up. And she didn't want to talk about dialysis, and quite honestly, I didn't want to talk about dialysis. And I kept thinking, with all the comorbidities, something else probably was going to come first. And lo and behold, finally her creatinine goes to 5, 5.5, and she gets in the hospital. You might have gotten involved in this, and she gets on dialysis, and 3 months later I see her there, and I've got ankles, and the lady just got a big grin on her face and beginning to walk again. Yeah. And she's been on dialysis over a year now, and every time I see her, she looks better than the month before. Yeah. So she's still on the uphill of continuing to improve.
I think we need to be upfront with them about that. Again, the another thing I mentioned for the families, it depends on what you bring to the table. If you have a lot of other things going on for you, especially atrial fibrillation, You may not be able to do much, but
You must have had a recent bad experience.
you have to have blood pressure to get the fluid off, and we're just not able
Well, I
to.
guess I'd back up one step and say pulmonary hypertension.
Yes.
Yes,
Oh
that's
my
the other
God.
bad.
Oh, what that new transplant y'all gave me this morning.
We're sorry.
Oh, great. You know, he's in clinic with his belly huge.
Yeah, we are.
What is
Just one other geriatric thought that I have.
Oh,
It's off now.
Medication.
That
You
why
can
that's
edit
why
it.
it's as generic as I could
Yes, thank you.
possibly
I
make my
You can
story.
edit it.
Just like the
I can edit it.
Oh, that's right.
To a degree. I can edit to a degree.
And I need, we need to
Can I
figure out what
hear
I
that
said.
first?
What did you say?
That one
Yes,
about,
I don't think
well,
we
but
said
the
that.
mortality data in Eastern North Carolina, Virginia, I don't think that can go on the internet.
Okay.
You can just take the discussion out.
I thought we were okay to talk
I
about
didn't even remember it.
Whatever happens,
Whatever
right?
happens in
G
Greenville
Vegas.
stays in Greenville.
G Vegas stays in G Vegas.
Our guest has a comment.
Can you edit it?
If I can just say that, like Dr. Sim was saying, the renal reserve is very low at the elderly. And you think about medications that we give them, whether it's for hypertension or diabetes or whatever, and they really have a little reserve and little therapeutic window in terms of too much, too little. And not only is their renal reserve low, but their cardiac reserve, neurologic reserve, all these reserves are really low. You start low and then go very, very slowly. You want to get there, and ultimately, typically start after those.
And actually, that was on the board review that we just went over with the fellows. One of the points was typically starting medicines at half the dose. That was one of the prognosis. Especially in dialysis patients, not just in elderly, but in all.